Hello, thank you so much for the opportunity to speak at this lovely conference. I am so sorry that I'm unable to be there in person. My name is Christina Dieli Conwright, and I'm an associate professor at the Dana-Farber Cancer Institute, Harvard Medical School. And I look forward to speaking today about getting to the heart of the matter, integration of exercise into cardio-oncology care. So first off, I'm going to start with the rationale. Why should we be concerned about cardio-oncology? First off, there are adverse effects of cancer treatments that affect the cardiovascular system. These are very vast and they may present acutely, early, or late. As you can see in this particular figure, there's a number of different cancer-related treatments such as anthracyclines, platinum compounds, and taxanes that impact various aspects of the heart, such as cardiomyocytes, coronary arteries, and cardiac conduction. In addition, we know there's also cardiovascular risk factors that an individual may present with that can be exacerbated during treatment, perhaps even before and later on. And so we constantly need to be thinking about prevention, early intervention, when do clinical stage interventions need to occur, and what are those symptoms so that we can try to protect the cardiovascular system. An additional problem is that the prevalence of comorbidities among cancer survivors is high. These have prognostic significance, independently affecting survival. This particular figure shows 4 different cancer types. And on the x-axis are the number of comorbid conditions that an individual may present with, all the way from number 1, which indicates liver disease, up to number 14, which is rheumatological conditions. And as you can see in all 4 of these diagrams, numbers 8 and 11, which correspond to hypertension and COPD, as well as obesity, remain relatively high across individuals diagnosed with these cancers. A third problem is that cardiovascular disease is the main cause of mortality among certain cancers. We know that individuals without a history of cancer have a lower probability of elevated 10-year cardiovascular disease risk, which is shown in the dashed line. So those who have been diagnosed with cancer have a higher risk of developing cardiovascular disease. In addition, cardiovascular disease risk declines with increased levels of physical activity. This has been exponentially demonstrated in epidemiologic literature over the years, whereby individuals who self-report levels of physical activity over their lifetime demonstrate protection against cardiovascular disease risk. One such way that we can directly measure cardiorespiratory fitness that's associated with cardiovascular disease is by oxygen consumption, which is performed on a test referred to as a cardiopulmonary exercise test. This is the gold standard for assessing aerobic capacity. It has high clinical utility and is strongly associated with all-cause and CVD mortality. This particular outcome, VO2 peak, assessed from the previous slide testing I denoted, has been studied extensively as well. So when we're thinking about when should we intervene with exercise, we know that exercise performed prior to initiating therapy does improve cardiorespiratory fitness. We see this noted in a 1.0 ml per kg per minute increase in VO2 peak, which is associated with an adjusted 9% reduction in all-cause mortality. Exercise improves VO2 peak on average about 2.36 mLs per kg per minute, which is pretty substantial given the increases needed to protect the heart. This particular diagram is a meta-analysis. You'll notice that over the next few slides, I will denote the arrows that correspond to the time frame of when the exercise is performed. So here's the data for pre-therapy that shows that exercise favors protecting the heart. This next slide shows the addition of yellow arrows, which are denoting but during therapy. This shows studies from over 14 trials and almost 1,000 patients from breast, prostate, lung, and hematologic cancers with approximately 15 weeks of intervention. There was an improvement in VO2 peak of 1.37 mLs per kg per minute, again with exercising favoring a change there. Physical activity performed during chemotherapy is also associated with better quality of life and left ventricular function, as well as post-treatment cardiorespiratory fitness. So important here is that simply by exercising during treatment, not only are there benefits of quality of life and cardiac health, but after treatment, those benefits are sustained in the form of increases in VO2 peak. So this is just an additional trial that we ran in our lab recently, thinking of the timing of exercise. This was a high-intensity interval training intervention to improve vascular dysfunction in sedentary, overweight, or obese breast cancer patients receiving anthracycline chemotherapy. We looked at this particular problem because breast cancer patients receiving anthracyclines are at a higher risk for developing these chronic diseases. Vascular function also increases the risk of stroke, heart failure, diabetes, artery disease, MIs, hypertension, and renal failure. We chose to use high-intensity interval training, or HIIT, because it elicits superior cardiovascular, body composition, and cognitive health benefits when compared to moderate continuous aerobic exercise. And this is the protocol that we used. So patients were sprinting or pedaling fast on the bike, 90% of their power output effort for 1 minute and recovering for 2 minutes at a lower intensity. And that alternated for over the course of 25 minutes. We found that HIIT improves endothelial dysfunction in this population, as noticed by the increase in the HIIT group with the gold bar there, where flow-mediated dilation improved, demonstrating that the vascular system improved performance. Unfortunately, the delayed or the control group got significantly worse. We also looked at arterial wall thickness, the premise being that the thickness in the wall would slow down or occlude blood flow, which would increase cardiovascular disease. And here you can see that we saw a significant maintenance of IMT in the HIIT or exercise sample. Unfortunately, in the control group, there was a worsening or a thickening of that intima media thickness wall. We also saw improvements in VO2 peak and, unfortunately, declines in performance in the control group. We looked at metabolic syndrome, knowing that there is an indirect relationship there with cardiovascular disease, which is shown highlighted here in the blue rectangle. And you'll notice that all of those measurements significantly increased from metabolic syndrome, including HDLs, triglycerides, glucose, and a comprehensive metabolic syndrome Z-score. What did not change was blood pressure and waist circumference. This was only an 8-week duration study, so that could have played a significant factor here. So going back to the when question, well, this remainder of this particular figure now with the turquoise arrows integrated shows post-therapy exercise and the impact that it has on cardiorespiratory fitness. And you can see the results here are in line with the other 2 time points, that exercise favors improvements in cardiorespiratory fitness. This is in over 27 studies, almost 2,000 patients. In addition, I wanted to also show a study we did with circuit interval-based exercise to improve vascular function. This was a pilot study with 90 patients diagnosed with breast, prostate, or colorectal cancer, not on treatment. So additional evidence to support the impact of exercise after treatment is completed. We found similar results to our HIIT trial in that exercise improved endothelial function. You'll see that on the blue turquoise bars there, with a large increase there in FMD in the exercise group. Again, the control group was significantly worsened. So really, from the perspective demonstrated so far, exercise timing is important to consider. It's cardioprotective and can impact functional capacity. However, there really is no bad time to intervene. If we think about these 3 time points as pre-treatment in figure A, during treatment in B, post-treatment in C, we might be thinking about what we're trying to achieve. In the pre-treatment phase, we may be trying to increase fitness in the individual while they prepare to undergo very harsh treatments. In figure B, we may be doing more of a maintenance to sustain whatever fitness they have during that time frame. And in C, post-treatment, we may be trying to then achieve a status of higher functional capacity based off of where they were at prior to initiating treatment. We also know that in the adjuvant setting and post-adjuvant setting, there are quite a bit of improvements as well. In adjuvant, with breast, prostate, and colorectal cancer, we've seen reductions in CVD events and CAD mortality. In all three cancer types, improvements in cardiorespiratory fitness. In the post-adjuvant setting with breast, prostate, stem cell, testicular colorectal leukemia, we've also seen some very positive results on impacting cardiovascular events and reducing all-cause mortality, improving vascular function, and also improving cardiorespiratory fitness. So again, really the message here is that there is no bad time to intervene. It really comes down to what is the ultimate goal we're trying to achieve. So how do we do this? How do we begin to think about intervening? And I think this is really complicated, particularly in the US model. We do not have standard of care cardio-oncology options for patients, but we've certainly thought about it. And some institutions have resources and programs that are ongoing. And we have certain models and theoretical frameworks that we can think about. But things we need to think about and consider when we're thinking about exercise as part of cardio-oncology care: what are the cardiotoxicity risk factors a person has? Do we have access to exercise testing and prescription? What are the considerations for the implementation, such as time, home-based integration, insurance coverage, and travel barriers? And when are we actually going to intervene? Primary, secondary, or tertiary prevention? And really this bottom right constituent here is pretty complicated. And this is going to vary, I believe, by state, by city, by institution, by country. That makes this area of work very challenging. So the necessary exercise stimulus to improve or maintain cardiovascular health is also unknown. We have quite a bit of literature to demonstrate that we can improve VO2 peak in primary and secondary prevention. We can possibly prevent cardiac function from declining in the primary prevention phase and possibly improve cardiac function in the secondary prevention phase. But we don't know much about cardiac injury biomarkers, aside from that with primary prevention, there may be a possibility to prevent substantial detrimental changes. So there's quite a bit of work to be done in this particular area. Not only what is the necessary exercise stimulus, but what are other outcomes that we can begin to look at related to cardio-oncology. And despite cardioprotective benefits of exercise, major knowledge gaps exist in this term we can call exercise cardio-oncology research. From a population standpoint, so far the work has been relatively homogeneous in that it's relied mostly on work within breast cancer. We need to begin to think about non-breast cancer populations, novel cancer treatments with cardiotoxic properties such as immunotherapy, and also think about those with established subclinical cardiotoxicities at initial diagnosis. We can also think from the outcome perspective. Cardiovascular outcome has been a primary focus, such as CRF or VO2 peak. We also need to be thinking about vascular health, clinically applicable outcomes, novel biomarkers of cardiotoxicity risk. And with intervention and study design, thinking about design and intervention to align with the desired outcome, utilizing a comparison group is going to be important. And we need to begin thinking about ways we can manipulate frequency, intensity, time, and type of exercise. Thinking about pushing the envelope more with resistance training only and what we can elucidate there, and also looking at balance and flexibility focused interventions. So fantastic model here of potentially how to implement or components, I should say, of how to implement exercise cardio-oncology programs into cardio-oncology rehab. Again, this would be covering risk assessment throughout the cancer journey, which would include a baseline exercise test as noted in the red check mark, thinking about potential venues of where this would happen. Is there an exercise facility, or would this happen at home or in an inpatient or outpatient setting? Potential services would include exercise testing and exercise training, but also nutritional counseling. And benefits would cover the gamut of optimizing CV risk factors, improvement in fatigue and quality of life, and also cardiopulmonary fitness. And lastly, there's a number of challenges, again, that will be unique to everyone: limitations in reimbursement or finances, heterogeneous cancer populations with varying toxicities, gaps in research, and health disparities. So as I begin to wrap up, I also want to emphasize that integrating exercise in cardio-oncology is also further challenged by disparities in marginalized populations. Individuals that identify as Black, Latinx, Asian Pacific Islanders, immigrant populations, indigenous populations, rural, and sex and gender minorities all have unique barriers and needs that are largely unaddressed in exercise oncology research. And these are aspects we need to think heavily about when thinking about exercise and cardio-oncology delivery. We have a number of trials that I'm going to just briefly give an overview of with no specific data presented at this point because they are ongoing. But I'd like to share what we're doing in our lab to contribute to this work of exercise cardio-oncology. We have the ongoing ROSA trial, which is using exercise to target metabolic dysregulation in obese Latina breast cancer survivors, funded by the American Cancer Society. Here, the patients receive a supervised virtual exercise program for 16 weeks. They can then opt into removing the supervision and continuing with the program, plus a follow-up, all to target metabolic syndrome, diabetes, and heart disease biomarkers. And we're just waiting for our last patient to enroll in trial, and we'll be wrapping this trial up. We have our THRIVE trial, which is targeting Hispanic and Black cancer patients who are receiving chemotherapy, and we're trying to increase exercise participation as part of the pilot. And then our secondary preliminary efficacy aim is to reduce cardiovascular disease risk. This is the first trial, to our knowledge, to intervene with exercise during chemotherapy in an underrepresented minority population group. And this is funded by the NCI mechanism called the U54, which is held between UMass Boston and Dana-Farber. So I'd like to end on what evidence-based exercise advice can we offer during clinic or in a conversation with the survivor that takes less than 2 minutes. Well, we've got some great exercise recommendations that are out there: 150 minutes of moderate, 75 minutes of vigorous aerobic exercise per week, 2 sessions of resistance exercise. That's great for those who have the time and the motivation to do that. We've also noticed that these guidelines have been updated in recent years to 30 minutes of moderate intensity aerobic exercise per day, 2 sessions of resistance exercise. But what's really important is also to reduce sedentary behavior, to move more and sit less, to find a way to be consistent so that we continue to exercise over time and not just go in cycles of ups and downs, and also to identify motivation. Some people are motivated by walking a dog, running a marathon, doing group exercise classes, but we all have to find our own personal motivation to exercise and help our patients to do so as well. So on that note, I'd like to acknowledge my collaborators, my individuals in my lab, sponsors of our research, our study participants, and I thank you for your time today. Please feel free to reach out to me with any questions, and have a great conference. Thank you.